Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. In today's episode, we are coming to you from the 2023 NEI Synapse in Nashville, Tennessee. Today, we sit down with one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations. In this episode of the NEI podcast, I have here with me today Dr. Thomas Schwartz, and we are coming at you from Nashville, Tennessee, the 2023 NEI Synapse. And I'm so excited to share this episode with you because in this exclusive extended Q&A episode, we have the chance to allow the audience to have some of their unanswered questions from today's presentation addressed. So Dr. Schwartz just finished delivering his exceptional presentation titled, Can You Say Hey? The Many Faces of Serotonin 5-HT2A. Welcome, Dr. Schwartz.
Great. Good to be here.
My first question for you is, would pimavanserin be helpful for Lewy body visual hallucinations and or agitation?
So I think for starters, pimavanserin is approved for the treatment of Parkinson's disease psychosis. So we know it helps for hallucinations tied to that disorder. It's an interesting question because Lewy body dementia shares some similarities in its pathology with Parkinson's disease. So I do think theoretically, yes, it could be helpful for this type of dementia and maybe others, and that would be considered off-label. I think at the end of the day, one thing multiple speakers here have taught about today is increased dopamine is the final common pathway that may create psychosis across disorders. But if you can manipulate serotonin, block that 2A receptor with something like pimavanserin, you can downplay the amount of dopamine at the end of the circuit. So I think it's theoretically possible that it could be helpful. Yeah.
That's great. The next question is, why are lower doses of mirtazapine better for akathisia? What can you say?
So I think mirtazapine as an antidepressant, again, that's its FDA approval. The doses range from 15 to 45 milligrams to treat depression. When we're using it off-label to treat movement disorder, we're really relying on its serotonin 2A antagonism. And that affinity is pretty high, so you don't need a big dose to block enough of the 2A receptor. When you're using mirtazapine to treat depression, you also want it to increase norepinephrine tone, and the bigger you dose that drug, the more norepinephrine you get. But we're not trying to give norepinephrine, we're trying to use serotonin 2A, and we get enough of it at the lower doses. How does 5-HT2A antagonism affect appetite? This person says many patients want to avoid weight gain, obviously. That's another great question. I think serotonin 2A antagonism is not necessarily a huge driver on appetite or weight gain. The negative is a lot of our medications, psychotropics that block serotonin 2A also block the histamine 1 receptor. They're antihistamine. So mirtazapine will do this. Trazodone can do this on the depression side. On the antipsychotic side, like olanzapine, quetiapine do this as well, and they're approved for depressive disorders. So it's really more the antihistamine part that drives up appetite. And some of these drugs block the serotonin 2C receptor. Mirtazapine does this, as do many of the antipsychotics. So the negative here is your adipocytes, your fat tissue, continues to grow. So you get increased appetite, you take in more calories, and your fat cells keep growing, unfortunately. Right. So 2A by itself doesn't really create all that. Unfortunately, the drugs that are good at blocking 2A carry all these other issues, other mechanisms.
Right. Wow, that's so interesting. Why do some people report increased dreaming or nightmares when trazodone is added?
So I do think when you add a medication that blocks the serotonin 2A receptor, trazodone, mirtazapine, the atypical antipsychotics, some of them are really good at promoting deep sleep. So when patients are on SSRIs, SNRIs, they get a lot of light sleep. We may even destroy their deep sleep. So if you take one of these patients and you put them on a deep sleep med, they might actually get into their dreaming sleep more often. So you kind of give them the ability to have a more normal sleep architecture than they're going to experience probably a regular amount of nightmares per se. So on that level, when sometimes we're actually improving people, giving them their nightmares back. And then you're right. I think there's other people that, we change their sleep architectures to where sometimes they have nightmares and they wake up more often. That's how we remember them. So it can cut both ways. It's a great question. But I think we change the sleep architecture, sometimes good, sometimes bad.
And is that something that can go away over time, or is that something that stays?
Yeah, I think yes and no. Like everything, there's a yes and no answer. Sometimes as you manipulate that serotonin 2A receptor, they do downregulate, and sometimes side effects can go away over a few to several weeks. So we do see that in some people, but unfortunately in other people, it's just part of their new kind of way of sleeping, and it doesn't go away. And if it's distressing, then we'd have to stop the medicine.
The next question says, can you speak to the literature for use of mirtazapine and venlafaxine combo? Any experience with serotonin syndrome as a result?
So this is a combination strategy where you take venlafaxine, slow release, and that blocks the serotonin reuptake pump and the norepinephrine reuptake pump. You combine it with mirtazapine that has multiple antidepressant mechanisms. It blocks serotonin 2A, serotonin 2C, and it blocks the alpha-2 norepinephrine autoreceptor, so you get increases in norepinephrine. So if you think about it, you're getting 2 increases in norepinephrine, and you're getting maybe 3 manipulations on the serotonin circuitry. So it's a very aggressive combination pharmacodynamically. So in some ways for treating depression, that's a good thing. If the SSRIs alone didn't work, we need to change the way the circuitry operates. So that's why we think it works in theory. There are really no large-scale studies. So specifically, the literature doesn't have a 100-patient study comparing this to placebo, let's say. So there's not a lot of literature. In clinical practice, we do use this combination a fair amount. I mentioned Linda Carpenter's work. She's out of Brown looking at mirtazapine combinations with SSRIs, SNRIs, which is pretty valid and good work. Very little signal for serotonin syndrome to answer that part of the question. You're not adding 2 serotonin reuptake blockers together. So is it possible? Yes, but the multiple serotonergic mechanisms are not, let's say, aggressive enough to the point to flood the brain with a lot of extra serotonin. So I think it's relatively safe.
Great. That's great. How good is the efficacy of nefazodone for depression as monotherapy?
So nefazodone is an antidepressant that was FDA approved. I'll have to date myself here. I believe it was the mid to late 90s. Probably late 90s. And then, it had some issues where it increased liver function tests. And now if you use it, you are going to want to monitor liver test before and after use. So maybe once a year, maybe like, when you take statins for cholesterol. So it certainly has that warning. It's very hard to get the medicine in the USA. There's not many generic drug companies making it. So I don't want to say it's not available, but it's hard to get. But if you can get it, it does work as well as any other antidepressant. It passed the same FDA standards. You need to get a pretty good set of your patients better versus placebo in at least 2 randomized controlled trials. So it was held to the imipramine standard that every other antidepressant was. I think there's clinical lore that it's not very powerful and it doesn't really help folks as much, but it has met the same standard as every other antidepressant. So from that point of view, I think it's just as good. The sedating antidepressants tend not to do sexual dysfunction, which is nice. So it certainly does have a niche. That drug is not as sedating as trazodone or mirtazapine, which also gives it a nice niche from that level. But I think it's equally as good if you dose it and use it right. Whether it works as well for anxiety disorders as the SSRIs and SNRIs, I'm not sure.
Okay. Does 5-HT2A blockade with mirtazapine help SSRI-induced sexual dysfunction?
Yeah, that's a mystery. There's different things we try to help sexual dysfunction from the SSRI-type medicines. Actually, agonizing serotonin 1A sometimes can help because that will restore some dopamine balance in the spinal cord, but it's really not a robust finding. I have not had as much luck with serotonin 2A, but again, I do try it, right? So trazodone is an antidepressant that is known to create priapism, which is, it's the exact opposite of erectile dysfunction. So sometimes you do get lucky, and I like the question. Theoretically, it makes sense. My luck in practice hasn't been great, but we do try serotonin 1A agonism, and you can try serotonin 2A blockade, but not always super effective.
Okay. The next question is, what about hepatotoxicity and drug interactions with nifazodone?
So we mentioned a little bit earlier with nifazodone. It can bother the liver in certain patients. And so when I use it, it's kind of like issuing a statin for cholesterol. So I think you do want to get a baseline AST, ALT before you start it. Then you titrate the medicine to where you want it, and maybe then get a new set of LFT, liver function tests. And if they're okay, then maybe you check it once a year. And I think that's a pretty reasonable approach. From a drug interaction point of view, again, maybe this is the cop-out, but the way I manage it, there's not a lot to contend with that really hurt people if there's a drug interaction. But it's a drug we use not a lot of. I said it's hard to get these days. I always plug it into a drug interaction checker. And there's several of those available, and certainly the pharmacy checks for you, but it is so idiosyncratic how we use it and what drugs it interacts with. I just check it every time. So maybe once every couple of years, I dispense it and use it, and I just refresh my memory on it, and I run an interaction checker. That's probably the safest thing you can do.
Okay. Well, that takes me to my last question for you, which is, do you have any strategies for treating dystonia besides anticholinergics, since sedating antidepressants have not been found to be really helpful?
So that's a great question. Today in my lecture, we talked about using serotonin 2A antagonism to treat particularly akathisia. Many of the atypicals have lowered the rate of akathisia, and we talked about off-label use of mirtazapine and trazodone. And maybe to some degree Parkinsonism, but we didn't talk about dystonia. I think it's a great question. Dystonia is pretty rare. We don't see a lot of it, and so there's not a lot of studies around it. And again, I'll use the word idiosyncratic or random. When people get dystonia, you can't really predict it. Might hit them once, could hit them 8 times. There might be weeks between an episode. So it's going to be very, very hard to study. So I do think in the acute setting, using an anticholinergic like benztropine, for example, diphenhydramine, triaxiphenidil, you need to fix that. And some dystonias, if they're around your voice box, can cut off your airway. So if it's certainly urgent, we're not going to wait for trazodone or mirtazapine to get in your system. So I do think the anticholinergics still are the standard of care. But we know that blocking serotonin 2A can help dopamine in the nigrostriatal system. So theoretically, if somebody's prone to dystonias or getting them and they don't want to be an anticholinergic all the time, you might be able to lower the anticholinergic, put them on a serotonin 2A blocker, but yes, give them a rescue tablet or two of the benztropine, for example. So if the 2A fails, they can get out of their muscle spasms. So I think you could use it, but there's almost no data studying it for those reasons.
Okay. Okay. Well, thank you so much for sharing all of this incredible information with us. And thank you for joining us and being on our show today, Dr. Schwartz.
Great. Thanks.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.